Morning, everybody, and welcome to the people who are attending this board. I hope you're out there. You will be aware that we are piloting a new way of doing things. This meeting will be streamed on YouTube and therefore open up the possibility of a wider participation for members of the public. It is the first time we've done it, and as you can tell, we've already hit one glitch in the fact that, well, I can hear all of the board, I cannot see them at the moment, which is somewhat of a disadvantage, but I'm sure we'll get that glitch sorted out. However, I can see the hands up facility and I can see the chat room. So please do participate in the normal way. I know Richard and James, as our present IT expert, you will keep me on course if my lack of visibility of the board becomes a problem. So welcome to a very snowy Suffolk. Some of you are experiencing snow, some of you aren't. And I hope we find you all well and no doubt preparing for Christmas. I've got one particular welcome today, and that is to the new members of the Council of Governors who may be in attendance today. Congratulations. I look forward to working with you. The whole board looks forward to working with you. You have large shoes to follow because there were some extremely good governors in our last cohort, and there are some we will miss very much because they have done their term of office. There are others it's a pleasure to welcome back again, and I'm sure that the well-established governors will do everything they can to help and support you as you grow into your roles. I'm very grateful for a number of people who sent their questions in advance. I have 4. If the responses are brisk, then we may be able to open it up and invite more questions. But at the moment, I think we will probably have to stop at those 4 today. But thank you for sending those in, because given the new technology, I think it's particularly important we had those in advance. So I'm going to start with a question that Florence sent in, which is very much about redeployment of staff and bed occupancy. And Helen, I'm going to ask you to answer 2 questions, if I may, Helen Beck, because Margaret also sent in, and welcome back, Margaret, to the governors. Margaret also sent in a question about staffing numbers. Now, all of these are number questions, which sounds as if they should have a simple answer. And I know you're going to explain to us why they haven't.
Thank you, Sheila. COVID times have made life far more complicated in what was already not a simple scenario. So I can answer the straight questions of bed occupancy now compared to last year. The headline figures are that this year's bed occupancy is 81% at the moment compared to 95% last year. But I think if you've seen things in the press, there's quite a complex story around why that isn't an indication that the hospital is empty and everything is fine. But given the complexity, Sheila, of that question, and also some of the questions that I think have come through around the current waiting list, which has also changed significantly, what I'd like to suggest, not to duck the issue at board, but to give it a little bit more time, is that I'm happy to set up a governor briefing session in the next few weeks for the new governors so that I can go into a little bit more detail about patient flow, bed occupancy, and also how we are trying to respond to the waiting list pressures, if that would be a helpful thing to do.
I think that would be extremely helpful, and thank you for that, Helen. I know that it's been a frustration sometimes for non-execs when we want one clear figure and it's not possible to give one. Steve.
So I just wanted to allude to and maybe suggest to some of the governors that if they went back and look at Chris Hobson's social media and printed media comments is the Chief Exec of NHS Providers. He has recently talked through some of the challenges of managing in a COVID context at winter and so forth. So personally, I've thought that was a very both supportive and helpful way of explaining some of the pressures that I know Helen will also elaborate on locally and so forth. But if the governors and members of the public want to understand a bit more about that, I would certainly recommend that as a source.
Okay, thank you, Steve. Could we arrange for the link to go somewhere where they can find it? Okay, thank you. Thank you. I'm going to move then to Liz Steele's question, which was very much around the use of virtual consultations, be it video or be it telephone. You know, there is a predicted shift of 80% of appointments being held that way. And Liz is looking for some assurance that it doesn't lead to problems of not getting a diagnosis or obviously patient safety implications further down the line. Nick, I wonder if you could pick this one up, or Helen, I don't mind.
I'm happy to, Sheila, thank you. So I understand where Liz is coming from in asking the question. Of course, traditionally, clinical staff take a history, examine the patient, do some tests to confirm or refute a differential diagnosis that they've come up with. The lion's share of working out what's wrong with somebody is in the story. If you don't have an idea, a really clear idea of what's wrong with somebody before you lay hands on them to examine them, then you're really very unlikely to find out exactly what the problem is. So an awful lot of what needs to be done can be done through talking to the patient. I always joke with kids in the emergency department that I wasn't clever enough to be a vet because I need to talk to the patients to understand what's going on. And I think modern investigations are so detailed and insightful that often they replace some elements of an examination. So if you're going to have a CT scan of your chest and abdomen, or you're going to have an MRI scan of your brain, that is going to provide even more detailed information than the most thorough of examinations could provide. So there are occasions where, for example, even before COVID, we would arrange what we called straight to test appointments for some patients who don't need to see the doctor before they have their investigation. Having said that, we're only looking to make something like 30% of our new patient appointments non-face-to-face, either phone or video, and perhaps 60% of our follow-up appointments. So it is that first time that you see the doctor for the initial diagnosis that's more likely to need to be face-to-face, but sometimes the diagnosis is very clear either from the GP or from the story, as I say. So I think we will find our feet. The doctors in the hospital are not under any obligation to make appointments of a certain kind or a certain number, video or phone. They will look at the story and call the patients for examination who they need to examine. And that might be that they need to see them sometimes in clinic face-to-face, and sometimes they can do that virtually. I think it is a new technology and we'll all be finding our feet with it. But so far, the majority of patients and the majority of doctors, although not unanimous at all, are preferring it because it does take away the need for patients, at least, to come to the hospital, hang around, for many of them wait for transport and so on. So I think it's a mixed blessing. We're learning, but I do think that our clinicians are live to making sure, of course, that they can provide the right service.
Thank you very much indeed, Nick. I'm going to move then to Joe's question, which is a question about vaccine and timing and the availability for care homes and for our frontline staff. And that's a question we'd all like a very clear and precise answer on. I think probably this one falls into your lap, Nick, as well. But
yes,
I want to assist.
No, this is me again, Sheila. I'm leading the vaccine programme work for us. We'd all like a clear and precise answer, and I'm really sorry that there isn't. Even the information that Steve's got in his chief exec report, the situation is evolving fast, and I was in a webinar from Simon Stevens and his top team at NHS England on Wednesday evening, the day that the MHRA licensed the Pfizer-BioNTech vaccine, to update us all on the Joint Committee on Vaccines and Immunisation, which is the government body that decides how vaccines should be prioritised and administered, whereas the MHRA is the organisation that decides if they're safe and under what conditions they can be administered. The JCVI announced on Wednesday that the priority, as Joe's pointed out in his question, should be care home residents and care home staff. Unfortunately, because of the very complex cold chain requirements of the first vaccine and the small numbers that we have guaranteed to arrive in the UK, so 800,000 doses is actually 400,000 people, because everyone who gets one needs a second one. 400,000 people doesn't go very far, even if you restrict it, for example, to only over 80s. We will get some of that 400,000 in Suffolk and North East Essex, although it was clear on Wednesday evening that there was definitely not a guarantee that it would be distributed on a fair shares basis. There may be some areas that have greater reason to wave of vaccine than others. However, the first place that will be able to deliver it has been, in our area, will be Colchester Hospital. They are the only hospital of the 3 acute hospitals that have the freezer that can store the vaccine at the required -80 degrees. And they are likely to get some vaccine as early as next week. The plan right up until Wednesday evening was that we would be expected to prioritise administration to health and social care staff. That has now changed to the over 80s. It's going to be really quite difficult to get a large number of over 80s to Colchester Hospital, and the vaccine, as Steve's outlined in his report, can't travel. This vaccine, the patient has to travel to the vaccine rather than the other way round, which is the normal thing we do with flu. So we would need people to go to Colchester Hospital. There will be some over 80s in Colchester Hospital, either as inpatients or outpatients, who are well enough to receive the vaccine, and it's very likely that they will be a priority group. Within a fortnight, it is expected, although not guaranteed, that the licensing restrictions on the vaccine will change so that the distribution can occur in smaller packages. At the moment, you get 1,950 doses of the vaccine, or you get none. And so obviously there's only enough vaccine for 400,000 people. Most sort of primary care network areas couldn't accommodate the nearly 2,000 vaccines that all have to be given within 5 days. So the next thing that the MHRA are working on is a licensing framework for allowing wholesale distributors to break down the vaccine packaging into smaller packs that could then be distributed in a way that allows primary care network sites to stand up and deliver the vaccine to the over 80s. It is given that the first site delivering the vaccine in SNE is going to be in North East Essex. It is extremely likely, and our ambition, that the first primary care network sites delivering the vaccine will be in Suffolk. We've got more meetings this afternoon, and there'll be more meetings next week, and I'm sure the week after. I am afraid it is a little bit the situation at the moment that just as soon as you get ready for something, and we were ready for a mass staff vaccination programme up here on the second floor of Quint's house, and we had a dry run for that just yesterday, then the goalposts shift and things change. But hopefully we'll have other vaccines licensed shortly. If the AstraZeneca Oxford vaccine gets licensed, then rather than the 800,000 doses of the Pfizer one that the country has bought, we have millions of, some people say 100 million doses of the AstraZeneca vaccine that we have bought. And that's manufactured in the UK and doesn't have any of the doesn't have anything like the cold chain problems. It just needs to be refrigerated, essentially. So that will be, if that gets a license, much easier to deliver. So I think it's exciting that vaccination is beginning, but we're a little way off mass vaccination quite yet.
Thank you very much indeed, Nick. There are a lot of uncertainties, aren't there, as to timing, but I mean, it is, I think I put it prosaically, perhaps to Steve the other day, there is light at the end of the tunnel, but we've got to get through the rest of the tunnel first. So it is going to be a difficult winter, but it's really good news that those vaccines are coming, whenever that may be. I have nothing in the chat room as far as I can see. I have now got that, even if I can't see you, which is very helpful. So I think at that point I will return to the agenda. My apologies to the questioners if they want to follow up. But as I say, I believe you do have the chat available. So if I could move back into the main agenda, and I took questions first because given that we're working in a different way, that seemed appropriate. So we'll move the resolution. Do we have any apologies for absence, George?
Not that I'm aware of, no, Sheila.
Thank you. Do I have any additional declarations of interest? I'll take that as no. I'm not proposing to alter the timings on the agenda, but I would ask people to be very focused and concise in their answers. The minutes of the previous meeting, can we move to those, please? And I will take them page by page. Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. You happy that I sign those as a true record? I will take that as yes. And I will move then, please, to the action sheet and the matters arising here. And all those on the first page are green. I'm going to say that, are there any questions that anybody wants to ask about any of those particular items? You have an update. We have one which is for today's agenda, which is 1880, and the rest are all uniformly for the next meeting. I see no hands up. I see nothing in the chat room. And the second page are all completed actions. So may I take those as complete? Thank you. I'm not getting any feedback. In which case, can I move to the Chief Executive's report? Steve, opportunity to read a very full report. Are there any particular items you just wanted to highlight?
Well, so I was going to say it's great news around the vaccine, and there is light at the end of the tunnel, but it's not going to be an easy task to do the mass vaccination that the NHS is getting ready for. But there's a huge amount of work, and I just wanted to say thank you to the team, Nick and colleagues, for all the hard work on that. We're still in the tunnel, though, as you've alluded to, and lots of great work around preparing for winter and restoring as much activity as we can. And there's a great paper from Helen on that we'll go through. I have been going out and back to the floor. So this is not in my report yesterday. I was in the Path Lab, and people might see from social media, I walked through all the various elements of the Histopathology Lab. Absolutely eye-opener. Staff morale is very, very good. The equipment that they are working with is very, very old, and it's clear to me that we will have to invest, I'm sure, quite substantially in our laboratory equipment. But I wanted to say a big, big thank you to all the staff and all the work on getting those staff back into West Suffolk, and I've previously alluded to all the great leadership that we've seen on that. I've also been out and about in the community, and my report both highlights some of the things that saw and experienced, and I think it's just worth remembering that community staff do work largely by themselves, dealing with many vulnerable patients, and certainly it seems to me that it's important that we both appreciate and acknowledge that. And I think in Helen's report, she also provides some updates around the additional work that we've been doing with community. But I want to say a big thank you to our community staff for all that they have been doing. There's a continuous focus on culture, and Jeremy's report will pick up all the elements of what we've been doing around Merseycare. But to me, some really significant lessons to learn around really focusing on the hurt that is caused by investigations, and how we think about how we respond to that, and the multiple stories and truths that emerge around cases, and being respectful of that. And I'm sure lots more great learning from the course that I and others have been on. The major thing that is there nationally, though, that is probably worth just pulling out is my final few paragraphs in the paper, where I make reference to the emerging legislation that is being contemplated by NHS England. That will be significant for the NHS. It's evolution, not revolution. This is about thinking about how the focus on collaboration is legislated for, and there will be both duties around provider collaboration, and we anticipate that ICSs will be put on a formal statutory footing, either via a committee in common or through a repurposing of CCGs to establish ICSs formally. There is a focus on place, and that makes reference to our alliance structures, and that is very much our direction of travel, and I think it's very consistent with what is being proposed. But we'll need to keep an eye on those national developments to make sure that we understand what it means both strategically and operationally on the ground. That's pretty much all I wanted to just cover, Sheila, but big thank you to the exec team and to staff for all the hard work over a few weeks. It's been extremely busy, and I hope my report conveys that.
Thank you very much indeed, Steve. And I've got a question from David, please.
Yes, Steve, just on vaccines, when we come to the organisation development report later, we'll see that take-up of the flu vaccine by staff has been lower this year than previous years. Given the vaccine is important for the protection of staff, but also patients to prevent nosocomial infection in the hospital, how do we plan to encourage staff to take up the vaccine, given it's voluntary? And will we sort of record numbers for the board as we do with the flu vaccine?
Sure. So I think I'll probably bring in both Jeremy on and Nick on that. That's something that we have been focusing on, and I know Jeremy is going to pick that up as well in his report, because certainly it's disappointing the levels of flu vaccine uptake that we've seen at this point this year, and that's something that we are naturally both curious about and want to understand, and also as it relates to what might be the effectiveness and the uptake of the vaccine. But Jeremy, then Nick, if that's okay.
Yeah, I'll cover the flu update in my paper a bit later, but we have administered nearly 3,500 flu vaccines, which is great. It is lower than from this stage last year, and I'll talk a bit more in my update later about why that might be and what we're doing to understand where the lower uptake is, and are still providing the vaccine, so the programme hasn't stopped.
Absolutely.
Thank you very much. Louisa.
Did Nick want to come in on around the COVID vaccine?
Okay, Nick, shall I take you first to answer that bit, and then I'll take Louisa?
Okay, thanks, Sheila. So I think, David, it was about how we're going to encourage staff to take the COVID vaccine up. I think we'll have to, because there's going to be a limited amount of vaccine, and there will be enough staff with their sleeves rolled up ready to take it, and hopefully those people will champion the vaccine. We had a brilliant discussion in the clinical directors meeting this week, initiated by Srijit Das, the new clinical director for emergency care, about how important it is that us as senior clinical leaders demonstrate through example the fact that we will be having the vaccine, and that there's the question really is, do we believe the MHRA as a regulator of safety? And of course, as doctors, we understand their rigorous processes, and we understand that we as an organisation have vast experience of the MHRA through our blood bank, and we know the attention to detail with which they operate. And so I think to be able to explain to people, that this is a vaccine that's been through a very rigorous process, and lead by example, then we will, of course, report the numbers. We will also have access to the numbers by breakdown of staff group and work location. So we'll know, as Jeremy, I suspect, we'll talk about later on, we're just waiting for the flu detail of where are the pockets that we can still target with peer vaccinators to get those numbers up. And we will be getting that same information for COVID. So we'll keep you up to date.
Thanks.
Indeed. I'm going to take Louisa and Alan, who both have a question, and then I'm afraid we're going to have to move on. So, Louisa, can I take you first?
Steve, thanks for your report. And you sort of articulate on the bottom page 31 around all the work that's going on to prevent sort of in-house infections. So there's a lot of work on infection prevention stuff. But if we look across the papers, we can see that waiting lists are increasing. And having had the privilege of attending the access meetings, we've also can see that we've got quite a few do not attends. So I appreciate we may still be in tier 4, but what assurances can you provide us that the communication strategy, reassuring our community to come in and have the treatment that they need, is the correct one? Because West Suffolk is doing really well in terms of numbers of COVID in the hospital, but we're still seeing that do not attend, which is perhaps quite concerning in terms of people out there who need help, and we're there to give it and they don't turn up.
Sure, Louisa. I'll bring in Helen, but certainly I think this is something that I've been down in outpatients again. People might have observed this on social media. Mr. Farmy, one of our ENT surgeons, had a full clinic and had several no-shows. I think we're just checking whether the reminder system that we've got in place is being as effective as we would hope. But equally, I think there is, still some, residual concern about the safety of the environment that's out there in the community, and we're working with that, and that's one of the reasons why we're trying to just reinforce the message. But I know this is something that Helen and the teams has been very focused on. So Helen, you might want to say a little bit more.
Yeah, Steve. I think there's two distinct different things. There's the people who just DNA, do not attend, don't show, and don't inform us, and that we are, as Steve said, we're checking that the text reminder service is as effective, but we're also planning to move across to a new platform that will be even better than what we've had before. So we have got some moves in place to do that. There is then another category of patients who are contacting us and telling us that they're not going to come in because they are worried about COVID. And those groups of patients are very concerning because they've made a conscious decision not to come, as opposed to potentially there's an admin issue. And quite a number of them are actually on our rapid access cancer pathways. And we've tried a number of things. We've had specialist nurses talking to them. We've written to them, and some of them still too anxious to come into the hospital. The latest initiative that we've had, which has worked well and we will continue to do on a rolling basis, is to establish specific consultant-led clinics to do a virtual appointment with those patients, to actually have a consultant-led conversation about their condition, their symptoms. If they are refusing still, or not refusing but are still unhappy, are there alternative treatments? What else can we offer them? So we are doing everything we can, although clearly it is it is then people's choice, but we're making sure we give them as much information to make an informed choice.
I suppose the thing to just reinforce from what Helen's just alluded to is that I think this isn't really about mass communication. This is about specialist communication and addressing the fears that people have directly by putting people in direct contact with both specialists and experts, nurse specialists and consultants, because then the dialogue around the risks of not coming in alongside the risks of coming in can be communicated effectively. But that's clearly very labour intensive.
Thank you very much indeed, Steve, for that answer. It is a complex situation, I know. Alan, you had another question.
A question to Steve on the proposed legislation changes. I'm conscious that we're not meeting as a board again until the end of January. And when we have to come up with some kind of response to the consultation, will we be sharing that with our staff and potentially with governors or the public even over the next month or so? I'm thinking particularly of the community staff who might be particularly interested in the emphasis on place and how that may change.
So it would be good to get the board's views on how you would like us to respond to that consultation, and whether we do that both individually, organisationally, or as part of the ICS. I know, for example, that Ed Garrett, who is the accountable officer for the ICS, has been working very, very closely and was invited to an event by Number 10 this week to discuss much of what's emerging in the thinking around the legislation. But what I would, in a sense, ask is, would we like to formally respond as a board, setting out our views on the legislation? And I think if that is the board's desire and wish, we could possibly either look to do it via scrutiny and then report to the January, in a sense, board meeting what our thoughts are around this. Personally, though, Alan, I think it's very much welcome, and it's very much in accord with our direction of travel. And I think the only probably salient thing for us to maybe consider is an aspect on which the briefing is pretty silent on, which is what this means for both NHS trusts and foundation trusts. My assumption is because it's silent, there are no proposals to change foundation trust status, but a desire for us to collaborate even greater than we do at present, although I think we do pretty well on that. That, I think, is maybe the biggest question that I know, speaking to people in NHS England privately, is something that that they are I don't think planning to legislate on, but that's the question in many people's minds in the ether. So what I would welcome is a bit of direction on whether we should formally, whether people want to formally respond to the consultation.
I think that's a really good question, Steve. There are two ways we can do that. Well, there are several ways, actually, because we could respond as part of the ICS. We could respond as West Suffolk Alliance, and we could respond as West Suffolk itself. I don't know if anybody wishes to. I said I would close after this, but it is a good question. Is it something that the board would like to see us responding on?
I mean, Kate might have a view from an alliance perspective.
I think it's a really healthy thing to have a conversation about, perhaps with some protected time to do it. I think the response, I can't imagine being anything other than aligned with the ICS one and the alliance one, because I think, as Steve alluded to, the content of the paper very much mirrors our direction of travel and what we've already committed to, which I think is a real positive. And I think through having the conversation and responding, it might just further affirm that. But I think it would possibly be healthy to chat through and spend some time.
I think it would. Can I suggest that Richard and I find some time available to do that? Okay.
I think what I would say, though, the context of this legislation and what we'll come on to, I suppose, in terms of private around the future system work, I think where we have a real opportunity to be a national, groundbreaking, path-breaking model for the future in terms of what I think NHS England is looking to see more broadly across the NHS. So it's really welcome and really, really exciting. We have a big opportunity here. So
I think our feedback is generally going to be enthusiastic. One thing that William Pope, the independent chair of the ICS, shared with myself and the non-execs yesterday was that although there is a deadline set in January, it is likely to be feedback past that time is likely to be welcome. But I do think, Kate, you're right. We need a conversation. I think it won't be an over difficult conversation because it's a direction of travel we're embarked on. But I think we need to have that conversation. I think we should put back a strong view because I think we regard ourselves as well on this path.
Sheila, just if I may, because we touched on future system and the thinking, we're about to consider in private board the preferred site and location for the new facility and the new hospital. We are committed to letting both staff, governors, and the public as know as soon as we can. We will need to work through with both the regional team and the national team around that decision. So I just want to convey that there will be maybe some delay and lag, but we'll try and make sure that people can understand both the decision and we can communicate that as quickly as we can to relevant stakeholders. And we will endeavour to do that with staff and governors before the public.
Unfortunately, the gift of when we announce it is not altogether in our hands, is it? But we're in a very positive place, so let's be positive, very positive about it. Okay, thank you, Steve, and thank you for those questions. I'm going to move on because we've spent a lot of time on questions this morning, and I want to move on to the report on operations. So, Helen, your operational report, please. I'm sure we've read it, but I'm sure there are things you wish to highlight.
Okay, thank you very much, Sheila. So I've started with the phase 3 recovery. I know some of the NEDs have joined the access meetings, which is our term for the meetings where we really focus on how elective patients access our facilities, hence the title. I think it's akin to painting the fourth bridge, as it is really intensive hard work, but I hope people got a flavour of the amount of work and effort that the teams are putting in to making sure that people are able to maximise the capacity we've got, given that we have to work in a slightly different way. The areas of focus moving forward really are day surgery and endoscopy, and we've got some good plans in place, so I'm expecting activity levels in those two areas to increase over the course of the next couple of weeks. The endoscopy work will be fundamental because that hits cancer pathways, 2-week wait pathways, as well as elective pathways. And there's some really exciting work going on there. So I am hoping that you will all in future reports start to see some real progress there. Sadly, the number of 52-week waits still rises because we are adding more patients to the list at the moment than we are able to take away. although the rate of rise is slowing as we focus on that. And I think it's important to say at this point, we're no longer in a position where we're just treating rapid access patients and then the longest waiters. There is a clinically urgent cohort of patients that clearly we're having to look, and that is sometimes for some of the very long waiting patients pushing out their waiting times even further. I'd said if I move to winter planning and COVID, I'd said I'd give the board a verbal update of where we are at the moment. And again, I will caveat this with we are absolutely not out of the woods and still need to continue to follow all of the guidelines. However, as we're sitting here today, we've seen over the last week a slight reduction in our numbers of positive COVID patients within our beds. We have 16 at this moment in time, one of those who is in critical care. So an improved position from a couple of weeks ago, and we continue to focus on that. I think, though, if I could just say in reference to the question about bed occupancy, we are probably putting aside about 60 to 70 beds because of COVID, not all of which are full, but we have to cohort and keep those patients safe. And that's what's really driving the under occupancy percentage as different from last year. If I quickly move, then I'm happy to take questions if people have got them, but I'll keep moving through. Otherwise,
David. A question from David, Helen.
Yeah, Helen, I just wanted to ask whether what the continuing relevance is of the local targets. If I think I'm right in saying that the local targets originally were developed before the national targets, and I know we have some very specific challenges at West Suffolk with rat plants, etc. And I know that through the access meetings, staff are working incredibly hard to get recovery. But I just wonder whether that gives confusion in having two targets and whether it's better not just to focus on the national targets at this point.
Yeah, potentially it does, David. I hope you will see that when we're talking about it, we are actually aiming for the national targets. But I think it's a fair point. We'd set up our business intelligence monitoring tools with both in, which is why it's probably easier to report them than not, but it's a fair point. I'll take that away. We may consider removing those lines from the spreadsheets for clarity moving forward. Some of you may have seen in the press the Think NHS 111 First initiative, and I'm pleased to say we went live with that on Monday. In a relatively small way as we pilot and move that forward. Grateful for colleagues from NHS 111 who've really ramped up the size of their teams and have additional clinical triage services in an attempt to divert patients away from the front door of the emergency department for those who don't need to be there and create the capacity for those that do. In terms of EU exit planning, you've got an outline here of all of the things that we have undertaken. We received an assurance template yesterday, which needs to be submitted by this morning. To check that we have followed all of the guidance and done everything that is required and requested of us. I'm pleased to say we will be able to complete that with a full green sheet, as it were, of positive responses to all of the requests. So we're in as good a place as we can be. And I think as a system, we have over the past year managed so many incidents that actually our emergency planning responses are fairly well oiled and fairly good. colleagues at ESNEF did a tabletop exercise around this a couple of weeks ago, and our head of emergency planning, Barry Moss, joined that to see whether there was any learning we needed to pull across. His view is that there were a couple of points he passed to us, but that actually, given everything else we are doing, there was little value in running yet another emergency planning exercise for this organisation. There was nothing that came out of it that concerned us. Alan, did you
can I just stop you briefly, because these are 2 questions and they may relate to where you are in your report. So if I could just bring those in, Alan, could you?
Could you go back briefly, Helen, 111? I've heard various views about whether this is a kind of heavy-handed campaign, if you like, whereby people are going to be prioritised arriving at 111 if they've booked, arrived at ED if they've booked, things like that. Can you just explain how we're coping with it and whether we're going to help 111 publicise it with our community? Do we actually want to change people's behaviour?
So yes, we do want to change people's behaviour, and as a system, we would be publicising that with colleagues across the system. I think it's important to say people get an arrival time. They don't get an appointment slot. So, and in the first day or so, there was some confusion around people thinking they were coming for a booked appointment. And I know comms has gone out both to the people on the phone lines and out generally to the public to clarify that. So we are trying, where possible, if patients clinically urgently need to come, they will still absolutely come. Those that are transferred by ambulance, and we will do what we always do in the emergency department, which is to triage them on arrival and see those that require to be seen urgently before anybody else. But this is an attempt to distribute the arrival of patients who maybe can wait an hour or two to avoid overcrowding, and also to divert some patients who don't need to come to the emergency department and can receive appropriate treatment elsewhere. So they don't come for a booked slot, which means they walk in and just go straight in, but they get a booked arrival time. Does that help, Alan?
Yeah, is there actually a live link to RED whereby RED can actually shape that pattern?
Yes.
Okay, good. Thank you.
Thank you for that question. Angus.
Thank you, Sheila. Helen, I'd like to just talk about Brexit, if I may.
If you must.
And I've got a point of principle I just wanted to outline, and then I had a couple of specifics, if that's okay. It was quite timely. Just as I was about to ask your question, something popped into my email that said France is looking to veto the agreement. And that was really my principal point, in that my worry with Brexit is people will think on the 31st of December, right, we've done it. And I just wanted to make sure, I'm sure you are, that we will continue to monitor the potential impacts of it well into next year and beyond on supply chains and the like. And I can see you nodding, but I wanted to.
Absolutely, Angus. So the first thing to say, all of the plans assume the absence of a trade deal. So we're working on a worst case scenario, and then if there is a deal, it might be better. But I think it's absolutely correct. I'm not expecting anything to look any different on the 1st of January. However, by the end of January into February, that's when we may start, if we are going to see interruptions into the supply chain. It is going to take a few weeks to play through. So absolutely, yes, that's the way in which we've established this.
Thank you. And then there's 2 specifics. You don't have to answer them. The first was, I noticed the point around reciprocal and cost recovery and the charging of patients from the EU. And I'm just conscious we've not always been brilliant at recovering debt from patients we charge. And I'm sure it's on the radar, but we should just bear that in mind in our planning in case that goes up. The second one is on data. I'm I'm comforted by what's said here, but my experience of data protection at the moment is incredibly uncertain as to whether or not it is safe and it's all protected in terms of transfer of data. And I just urge the teams to make sure that they keep very close to it, because it's more complicated than Brexit, but I'm happy to take that offline if that would help.
Yeah, thank you, Angus. I think just to say the team of people working on this include our supply chain expert, our head of information governance. We've got a team of the relevant experts. I think you're right to say, and the paper alludes a couple of times to the fact that we haven't actually seen any guidance yet. No. We've checked what we can, and we are poised to react rapidly if we get a change in circumstance. I think that's as best as we can prepare at the moment.
I think that's right, yeah.
I've got his hand up, and then Helen, I'll come back to you for the rest of your report. Craig.
Thanks, Sheila. It's just a quick one. I couldn't let Angus's comment pass without a response. All the audit reports would suggest that we are highly effective in identifying patients who should be charged for their care. You're right that there are a number of those patients that we end up writing off the debt because it's not economic principally to chase that debt, or it's impossible to chase that debt. So although we write off a number of debts, we're highly effective at identifying those patients in the first place. So there is a balance, and you can't just look at one data point in isolation. But your point is not lost, Angus.
No, well said, Craig. As you know, I was referring to one data point there, so thank you for correcting me.
Thank you, Craig. Okay, thank you. And I'm going to move Helen back to your report.
Thank you, Sheila. So in terms of the community services update, I'd like to welcome Jenny McCrory into the meeting. Jenny is one of our team leads for Sudbury, and we've invited her just to talk to us about the digital work and how that has felt on the front line and what impact the teams might feel. Just before Jenny speaks, there is quite a lot in the paper around the community engagement exercise. I don't plan to go into that because we are planning to use next week's board workshop to give some detailed feedback around that. So we'll pick that up there. But otherwise, can I just hand over to Jenny for a few minutes, please?
Jenny, welcome to the board. I can't see you, but you're very, very welcome. And I would ask people to restrain themselves on the rest of the community, because there will be a longer discussion. We'll have the opportunity to tease that out next week. So Jenny, welcome, and over to you.
Thank you very much. Good morning, everyone. Sorry you can't see me. I'm sure my camera's on, but never mind.
Everybody else, a blessing. I have a glitch. Go on.
So far, Sudbury, Newmarket, Haverhill have been migrated across to the new IT, and certainly 2 out of 3 of those experiences have been incredibly positive. The people who came, the IT people who came and worked with us were amazing. They were incredibly supportive. No problem was too small. Those of us who needed hand-holding through IT, they held our hands. Those of us who allowed us just to fly with it, it was great. I can see how it's going to improve efficiency, no end. Already the applications are just quicker. The laptops are new, so they work better. It's good to have that confidence now that all of our information that used to sit on various servers now sits on one, and it's cloud-based, and we won't lose things. And that's always been a huge worry for us. The fact that we can now more easily share information between ourselves, the fact we've got access to the full address book so we can easily find people across the trust is really excellent for us now. I think we feel much more part of the whole now, and we've got access to your intranet so we can see everything that's going on and really be part of the whole there, which is really positive. Locally, having that IT support that's dedicated to community is also a great boon to us. So we know who Gary and Martine are now. They'll be here like a shot if we need them, and talk us through things. So again, it's much more efficient because any problems we have get sorted out very, very quickly, and in a much more hands-on way. So that's really good. Yeah, the only problem has been poor Haverhill, who've had a really rough ride with it. And the team lead there told me that she didn't mind me telling you that it's almost pushed her to the point of a nervous breakdown. They've had continual IT issues, server issues, slow connectivity, not able to access their emails. And 2 or 3 of them have had to go through 2 or 3 laptops just to find one that actually works. So whether that was their locality, and they were the first to go with the migration. So, but certainly, if that was the case, lessons were certainly learned, and for Newmarket and Sudbury, it couldn't have gone more smoothly. So it's 2 out of 3 really positive, and long term, once Haverhill is sorted out, then they will obviously also find all the positives that we are in communication and contact and efficiency. So that's how IT migration has gone for us so far.
Jenny, thank you. That is really positive. I wish it was overall positive for everybody.
Yes.
Do we have some confidence that Haverhill is getting its issues addressed, and are we making any progress?
Yes, I think we are, Sheila. And Sarah Judge, who's one of our expert digital leaders, has really been focused on this as well. And I think it's fair to say that as the first one, we were really grateful for Haverhill for being the first one, but the first one over the line is always a little bit more challenging. But generally, our IT colleagues feel that things are improving with every step of the way. So that's really good.
Okay, that's reassuring. Thank you. Alan, you had a question.
It's really a question probably for Kate and Craig, as well as Jenny, which is there a vision that as we move to more of a place emphasis, that this data, when appropriate, could gradually migrate further to our other colleagues in the place? So whether it's social care colleagues or mental health colleagues or whatever, is there a vision that ultimately we could grow into an even stronger place-based IT system?
So yes, Alan, and you can see in the report and the later digital board report about the progress we're making with HIE. So that's the Healthcare Interface Exchange. So that's where staff across the health and social care system can view a common patient record. So some of the stuff that Jenny talked about ease of access to information is absolutely the thrust of the digital strategy, and we are making significant progress along those lines. So yes, is the short answer to your question, but Kate can probably expand on that.
Kate, not at too great a length, please.
No,
Kate.
no large expansion. Jenny, lovely to see you, and thank you for such an open and honest piece of feedback. Alan, that is, as Craig said, that is absolutely the plan, and I think that it's very necessary to say out loud how tricky that is. And going back to the earlier conversation about the document that was released last week about the the emphasis on place-based and the future for the integrated care systems, this hopefully should help to unpick some of those things, because they need to be done at a national level. And we're years into this journey, so I think that we're probably further ahead of the game than most of the country in it, but there's still more to do. The point I wanted to make was just, and we've had this conversation at board before, despite the fact we don't have that level of connectivity that we'd like to have, the team still work brilliantly with their partners in those areas, through relationship, through conversation, through just the old-fashioned ways of being, and supporting patients together. So it will help absolutely, but it's not hindering probably in the way that it could do because of that.
Yes.
Thank you, Kate. Steve, you just wanted to come in.
So I wanted to thank Jenny for presentation and for all you've been doing supporting the teams through a challenging migration. So big thanks, Jenny. Just wanted to ask you, is there anything more that you require, not just your teams? You've been very gracious around your teams, but in terms of support from us and the board. And also, I didn't know. It seemed a great opportunity to ask you, just in terms of, how is morale in the teams more generally, and is anything that you need as we go into the next few weeks and this very busy winter period and so forth. So an opportunity to really just communicate to us all, how things are, on the ground more broadly.
Can you all see me now?
Yes, we can.
Oh dear, I just realised if I
Jenny,
was portraying...
it's just me. There's something wrong with my computer. I don't have vision.
But we've all read your face though, Jenny.
Yeah, I just realised that you can probably see my face going like, oh my gosh, how honest shall I be?
Very,
yes.
Morale is it's half and half. It's not all low and it's not all high. It has been incredibly busy. So the low bit of morale really is because we're at, we're however many months in to an extremely busy period. And for us in the community, it has just remained constantly busy, taking on new policies, new ways of working, new things, and then things like the IT migration coming on top, and then there's health roster being rolled out, and we're sort of still dealing with everything else, and an awful lot of other things are also being piled on top. So we're coping, and it's not decimating the teams in terms of morale, but it is all challenging. The good things are that we're very grateful to the board and whomsoever for supporting us and getting additional agency staff to help the nurses. That's been great. We've got 3 in Sudbury today, which is amazing. Brought us up to just below even then our minimum numbers. So imagine how it would have been if we hadn't had that. So that's really, really good, and that does help boost morale because that helps us see that real practical solid things are happening to support the teams. I think therapy morale is probably lower across all of the teams, more than nursing, because I think they feel that during COVID their waiting lists went up, whereas the nurses, a referral comes in, they have to meet that need straight away. So there's no build up and pressure, whereas the therapists have got very long waiting lists now, in most teams, and the pressure is still on, of course, to support the patient flow from the hospital, which we all totally understand and totally support. And that's where we put our focus because of the reasons why that's so important. But it does mean they have this pressure always in the back of their heads. What about our community patients? What about 120 on our waiting list who aren't being seen because of everything else? So their morale is quite low, and in my team I've lost a couple of staff through it, which is a real shame because they're great. They were great physios and OTs. So nurses I think are holding in there, seeing what you're doing to help them, and keeping going with it, even though it's tiring. Morale though in therapy is probably a bit lower because of those reasons. That's the honest answer.
Sure. But you feel you're being listened to? Yes,
definitely. Yeah. And
right.
Like I say, those practical steps being taken to help us is great. Yeah.
Thanks for all you're doing, Jenny.
Okay.
That's on to the team. Thank you. Really appreciate it.
Thank you, Jenny. Steve done that for me beautifully, but please pass the whole board's thanks on because, the community teams are often less obvious to the outside world. They think about the structure of the hospital and people in it. They're the people who keep people at home, people healthy in their own familiar surroundings.
Yes.
And it's having spent time out with them, it's a constant round, even in the best of times. And these are not the best of times. So we would wish them well for the winter and hope that it is as easy a winter as it can be under the circumstances. So my thanks, and please pass it on from the whole board.
I will. Thank you.
Thank you, Jenny. And can I now come back to Helen And I don't know what you've done, James, but I know you're hiding at the back of the meeting. I can now see everybody, and it does make quite a difference. Okay, Helen.
Thank you, Sheila. So in terms of the performance report, I've talked a little bit already around some of the phase 3 recovery, and I've talked about COVID. So to be honest, Sheila, I am very happy to take questions from people rather than go through individual sections of the report. I'm happy to answer any questions.
Thank you, Helen. I think we've probably covered off most of the questions as we've gone along. And I think too, because you had a question at the beginning from the governors, which explored some of those areas, probably I've got no more hands up. So I'm going to assume that we can move on into the quality and performance report. So over to you and Sue. Are you going first, Helen?
Sorry, Sheila, I'd already moved on to the performance section of mine.
I'm trying to fix the IT.
You are? No, that's absolutely fine. So I think I've covered off anything I would have wanted to pick up out of this, and I'm happy to hand it to Sue to pick up the quality.
My notes you have. Thank you. Yeah. In which case, Sue.
Thank you, Sheila. The narrative around our quality indicators is there. I am happy to take any questions. As requested at the last board meeting, the section relating to the perfect ward and COVID related incidences will be captured now elsewhere, and so therefore they are included in this month, but next month the infection prevention control will pick up the COVID related incidents. And we are doing a lot of work to review the perfect ward audits and where they will best be recorded and reported through this board. I think to say the duty of candour has slightly deteriorated this month, but we have highlighted that is due to diagnoses such as MSSA, which have to go through a whole process before we can actually declare the duty of candour or decide what element of that we need to do. Falls have seen a slight decrease this month, which is good news. We still continue to focus on how to minimise falls, and I'm absolutely delighted to say that our new falls lead coordinator is in post. She is a physiotherapist, and I'm really excited about this role and how it's going to help us support the organisation in being really proactive in the safety of our patients with regards to that. The other thing that we want to talk about is we had our Stop the Pressure Days this month. We still are focusing on our harm-free care with regards to pressure ulcers and our quality improvement, and community are working really hard with that because we do know that we have got a high prevalence of pressure ulcers in the community. I'm happy to take any questions. I wasn't going to raise anything else unless anyone would like me to.
Okay, thank you, Sue, and thank you. I know there's been questions about the quality and performance report because it has changed and evolved, and it's a difficult time to get consistency in it. So any feedback is welcome, I know, and Sue would welcome that. Yes. Alan, you had your hand up.
A suggestion really, as the vaccination issue is going to be a high profile one for quite a long time, would it make sense to have a simple chart at the back of our IQPR which shows our progress on both flu vaccination of staff and COVID vaccination of staff, just for interest, unless it's going to appear in other places?
Nick, I think you're wanting to answer that, aren't you?
Sounds like a great idea, Sheila. I'm happy to get that added in for next time.
Thank you, Nick. That would be really helpful. Angus.
Thank you, Sheila. See, personally, I like the report, so that's my feedback on it. So thank you for that. Can I just touch on duty of candour for a second, because
You've got on to mute, Angus.
God, I managed that without any hands. That was quite impressive. Thank you. I just wanted to talk about duty of candour, if I could, because it seems like one of those perpetual ones we never can quite solve. And I'm conscious looking forward in the papers that it's read in the improvement plan.
Yeah.
And I guess my question is there something, do we need a different way of looking at it, or are we doing all we can to try and solve this conundrum, or are we just trying to do the same thing again and again?
So we are absolutely reviewing the way we provide duty of candour, how the quality, and some of the reason that we're still red on the improvement board, Angus, is because it's around the quality and the ability to deliver it and how we're doing it. And Nick's got his hand up, so I think he's going to want to come in. We will be reviewing it through our PSERF programme and how we deliver the duty of candour. So some of the numbers are how quickly do you deliver it, is the qualitative aspect of it, of how it's delivered in a meaningful and compassionate way, and that is some of the work that Lucy is doing with the team on how we could do the training across the organisation to support staff in being able to do that, rather than it just being a letter to say we're investigating this issue and then we can tick that box to say we've achieved candour. It's much more important to have those really, really good quality conversations. But I'll let Nick come in and think he might want to add something. Nick?
Thanks, Sue, Sheila. So really just saying, I've yesterday reviewed the job description for the new Associate Medical Director for Quality and Safety, and one of the key functions in that role is to oversee duty of candour and to work with the patient safety team and the Associate Director there to make this happen. So we're conscious that it isn't quite right yet, and we have plans to try and do something differently, because as you allude to, just doing the same thing over and over again is likely to produce the same results.
Yeah, fantastic. Thank you. Thank you both.
Thank you, Nick. Thank you.
Thanks, Sheila. Sue, thank you for your report. I think it's very comprehensive. I just wanted to ask you a question about pressure ulcers. I know that you're doing a lot of work in that area, but in your view, given that there's a consistent rise in the number of incidences, what do you think the underlying cause of that is?
So within the community, we have seen some trends relating to concordance and the ability for our staff to get into patients' homes to assess and to review. Some people have been cautious about how many people they want going into their homes. We offer advice and we provide support equipment, but it is really then in the community, it's not something we can keep a daily contact on. Whereas within the ward environment, you've got your nurses on the ward that can assist daily. Within the community, you make a plan, you then come back. But we have a really, really good tissue viability nurse who works with the community teams. The community matrons are absolutely fully engaged in this work, and so consequently I am absolutely optimistic that we will get this this will improve over time. But unfortunately this is a national trend, it's not just within our own organisation, and it's difficult to. The biggest thing we found is concordance, and that's concordance with being concordant with the suggested treatments and methods that we've put in place.
Okay, thanks, Sue.
Thank you very much indeed, Sue. Were there any other questions for Sue's report? My impression is the only person who's commented on the style and quality was Angus, which was very positive. I would echo that. Thank you, Sue. In which case, could we move on then to Craig at Finance, please, Craig?
Thank you, Sheila. I am planning to be very brief in talking about the finance report today. We are broadly breaking even year to date, and we continue to forecast that we will break even at the year end. You will see from the report that we are underperforming against our cost improvement programme, as we have done throughout the year, the principal reason being the focus on COVID. Helen and I met with the PMO and the finance managers yesterday to reinforce the need to achieve the cost improvement programme in month 12 of this year, to ensure that we go into next year recurrently in balance. But as was in the action points at the start of the meeting, we will bring something back to the January meeting to illustrate progress on that. The cash position remains healthy, so we continue to have around £25 million in the bank account, principally because of the cash flow support that has been provided to the whole NHS this year. There is a focus within the organisation on our capital programme, and we'll be considering that further in the closed part of this meeting. But other than that, Sheila, I wasn't planning to highlight anything, but I can see there are a few questions coming in.
There are some questions. And Craig, before you wind up, just a brief comment from you would be useful, because we're going to move out of this strange world of COVID eventually, and money will suddenly become extremely tight within the system. And I suppose it's just, if you can just allude to some of the future planning that you may and the team may have in place to address that, because actually the future looks quite challenging. But I'll take the questions first, because they may appertain to that, if I may, Craig.
Of course.
David.
You virtually asked my question, Sheila.
David, I do apologise.
Which was obviously the vaccination news is great, but I think that's going to then lead to more scrutiny around finance in the next financial year. And we've obviously got additional challenges of RAP banks and everything else. So I just, as we start to come to the new planning round, I was wondering what assumptions we're going to make around income. And then also associated with that, we've incurred additional costs during COVID, which we've been able to recover. To what extent and how easy is it going to be to get back to baseline expenditure and remove any of those additional costs that we've incurred over the last period?
Okay, shall I take Rosie's question?
They may allude. Rosemary, is yours a very separate question?
It's a very simple question.
Okay, we'll take the simple one, because I've got a feeling mine gets to be complicated.
Okay, thanks, Sheila. Craig, just looking at the CIP plan, going forwards, there's rather a big amount in the other category. I was just wondering what sits in other. You've got a lot of categorisations, but there's a rather large figure in other in the CIP plan. Can you give us an idea of what is actually in there? What does that mean? Other.
Yes, so those are a collection of smaller schemes that principally are around the way in which we manage staff and vacancies. So across the organisation, when we set budgets, there will be times when posts are vacant, and the gap between that post being vacant and it being filled represents a financial saving where that isn't covered by temporary staffing costs. So that's one of the biggest elements of those in other, but it is a collection of smaller schemes from across the organisation. When we present the cost improvement programme to the board in full, you will see a much greater breakdown of all of that. It's just for the monthly monitoring purpose. We tend to aggregate those into other, because there's no one scheme in there that gives rise to a reasonable description.
Okay. Thank you, Craig. To the more complex one, and then I think we need to move on.
And it's not unrelated, so I'm glad Rosie asked the question before I answered the longer one. The way in which we are planning for next year, as I said in the introduction, is around ensuring that we achieve our recurrent CIP in month 12, so that we go into next year with a baseline financial position that broadly reflects the way in which we went into this year. That's a real challenge, and some of the uncertainty that we've got is around the impact of the vaccination programme, particularly on staffing availability. So there is still a degree of uncertainty as to levels of sickness that will occur on the back of the vaccination programme. That has a financial impact, and organisations across the country are unsure as to the impact that will have on the financial position. So we continue to monitor that. The bigger issue for next year will be around volumes of activity. As we try to recover the position that's been created this year through activity not being deliverable because of COVID, that backlog is really expensive. And you only have to look at the investment that occurred between 2000 and 2010 in the health service. A massive amount of investment was required in order to make a step change in the waiting time position for organisations. And that investment was required over a sustained period of time. So this is not something that will be achieved in any one financial year, and it will be expensive. At the moment, the Department of Health have indicated that £3 billion will be available next year in order to recover or partially recover the situation that's been created this year. But there is so much uncertainty at the moment, but you're right to highlight the very issues that will have a bearing on our financial position next year, which will be around the levels of staffing that we enter next year with and the expectation as to the volume of activity that will be deliverable. And we have our own peculiar challenges around that. All of that will be played in, and we will make an attempt to come back with a forecast position for next year and a plan for next year. But I think it's fair to say that there will be more uncertainty in next year's plan than there has been in previous plans. However, we will enter next year in probably a stronger financial position than we have had for the last 10 years. So the strengthening that we're seeing this year in our financial position will stand us in good stead going into next year, but there will still be uncertainty. But you've highlighted all of the issues that you will see, and I would expect you to focus on when that plan's presented in the coming months.
Great, thank you.
Thank you, Craig. It's good when you're going into a rough period to know you're as ready as you can be, so to speak. Steve.
So two quick points. In terms of next year and the future financial context for the system, the document that I alluded to in my Chief Exec report does signal a shift towards block contracts. We've been on that for a while, and I think we are pretty embedded in that in terms of approach and understanding, which I think further just reinforces how well aligned we are to the future strategic vision. I think the second point that I would make is clearly as we exit in a sense the COVID winter into a new COVID normal, the focus will be very much on recovery, and there is money set aside for that. That will be the future challenge, but many of those parameters are slightly up in the air. So that, I think, will be our very much our focus going forward. I'd expect it to be.
Okay. Thank you, Steve, and thank you, Craig. It's going to be, yes, a new world, whatever the new normal looks like. Okay, thank you very much indeed. In which case, can I move from the money to the area it's spent? Jeremy, on the people. So can I move to your OD report, please?
Thank you, Sheila. Good morning, everybody. Slightly less pages from me, but still just as important. I want to start actually this month with the focus on the Putting You First awards. It's on page 84 of the report. Both of these nominations highlight just wonderful examples of the personal level of care, compassionate care that has been provided by Sarah and Victoria in these two instances. I'm not going to read them because they're there for you to read, but they really sort of parachute you into that moment to help you feel the level of support and care that these patients experienced as a result of Sarah and Victoria's attentiveness. So I just really, on behalf of all of us, want to thank Sarah and Victoria and really to celebrate and appreciate what they bring to our organisation. So thank you to them both.
Thank you, and they are two people very worthy of celebration, and an example of the kind of care we would hope is delivered all the time. So thank you, Jeremy, for bringing those to us.
On the previous My report, it gives a bit more detail from what Steve highlighted in his report around the cultural development in the organisation. And so during November, over the last month, we've been taking part in the training that Merseycare Trust provide with Northumbria University. We formed a group of 10 of us who are a guiding group for this, who will become a learning set that will lead our work to develop this here at West Suffolk. And the report gives you some detail around sort of what we learned. And in coming reports, I'll be keeping you updated with the progress of this work. We are, of course, not starting with this work from square one. There's a lot of great work going on in our organisation to develop the right culture, and it's really important that we join that up and do it together. So whether it's the work that has been happening for several years now on human factors, whether it is the learning from our 5 o'clock club in November around rudeness and civility, and how that plays a part in teamwork and safety, and the speaking up safely work that we as a board are responsible for, but we have our 2 new Freedom to Speak Up Guardians delivering. It's important that we join all of that up so that it is coherent and that we identify the common thread that runs through all of them. And that is going to be happening in December. We've got meetings planned for next week to bring that together. For me, the common thread that runs through all of those is psychological safety and people feeling safe to speak up, to suggest ideas, to be at their best, both for patients, for relatives, and for colleagues. And that's, I think, is going to form the focus of how we take this work forward. In real practical terms, the learning from the training that we took part in November looks at the immediate response from the organisation when something goes wrong, whether it may be a clinical incident or it might be a problem between colleagues that becomes a HR issue. The response that we have really dictates how people feel, the openness to learning that there is within teams and within the organisation, where we focus on learning from errors and mistakes rather than seeking retribution. With that in mind, the board will know that we took the decision to pause the live HR cases that were in train when we started down this road with the Just and Learning culture focus. My team have completed that work. In my next board paper, I will give you the numbers around that, but I'm pleased to say at least sort of 3/4 of those cases we have been resolving either informally or through alternative means, rather than needing to take those to a formal hearing. And I'll be able to give you some data around that in my next board paper. So I'm sure there'll be some questions on that in just a moment. Just before I close, we've already made passing reference to Brexit, and we've given an update in this paper around the support that we're providing to the 400 or so staff that currently work for us, who are who are from EU countries. And whilst the pandemic has paused our international recruitment programme, we have restarted that, and there's some information in my report there around recruitment from the Philippines, but also from Nigeria, and the work that the recruitment and nursing and education teams are doing on that. We have also discussed the flu vaccination. I don't think I've got anything further to say on that, on top of what we've already discussed, but obviously happy to take any further questions on that or on anything else in my paper. Sheila, thank you.
Thank you, Jeremy. And I'd ask board to note, you asked for feedback, because this is a new style paper, and it's very much developing. I think we very much welcome it, but I know that you would welcome feedback from members of the board if they would like to give it. And it doesn't have to be now. Davis, that is.
Thank you, Sheila, and thank you, Jeremy, for an excellent report. I think it's great. I met with the Freedom to Speak Up, our new Freedom to Speak Up Guardians, yesterday for a routine chat, and we were talking about the Mersey Care training and noted that the training had been delivered to 10 senior members of the trust. But clearly the learning from that, the Just and Learning culture stuff, needs to be disseminated throughout the trust. So is there an expectation that that learning is going to be disseminated throughout the organisation, not just senior managers?
Yes, absolutely. It is for everybody. Everybody has a part to play in this, whether or not you have a team leadership or managerial role. We have come across some resources that Mersey Care themselves have published this week, so they have some e-learning resources that help to spread this knowledge. So we will be doing that, yes, absolutely, bringing it to life through how it is hardwired in our policies and processes.
I have to comment before I come to Alan. I particularly like your idea that we need to, or your thought, we really do need to bring the variety of good work in the organisation together. And I think it was one of the Freedom to Speak Up Guardians who said we need a West Suffolk way of expressing this, which combines all those elements.
And I would just say that yes, the majority of the 10 were senior staff, but 2 of the 10 were staff representatives, and they're in that capacity, both medical and non-medical, and their input was very active and very valuable in the discussions we had during the training.
Thank you. Alan, and then Angus.
A question for you and for Sue, really, on the Nigerian sourcing of nurses. I'm conscious from other trusts that that's quite a big pool of talent there. And I'm wondering, can we learn from the fantastic experience we've had with the Filipino community that we should offer them some particular support? It's going to be a very different kind of support than the Filipino staff because of the different culture. And I'm wondering if that's something we can consider if that grows.
Yes, absolutely. In advance of their arrival, we did reach out to other members of our staff who are from Nigeria or have connections with Nigeria to help provide that level of welcome and support to the newly arriving nurses. And that's something that we will continue with and also get some feedback on to make sure that it is having the desired effect.
Okay, thank you. Angus.
Thank you, Sheila. Jeremy, I find the report very good and easy to read, so thank you very much for it. And I don't know if this is a question or a suggestion, but I think, as you rightly flag, developing and delivering a culture is a long-term game, and there's lots of different ingredients to it. And I share this with you. Where I currently work as an executive, they take a different approach to their performance management, or we take a different approach to our performance management, where we very consciously look at what and how, and they're separately measured. And I just wondered whether in the plans we're really thinking about how does the performance management approach serve our culture as we move forward. It's a suggestion, and you might already be on it.
Well, no, I'd love to know more. I think it's something that I would really appreciate being able to talk to you about outside of the meeting, because I think that starts to get into the wider the wider ways in which culture is influenced
in
the organisation. So I really welcome that suggestion, and
happy to do that, Jeremy.
Would love to have discussion about it.
That's a really useful suggestion. Thank you very much indeed, and we'll leave you two to have a further conversation. So thank you for that. Were there any other questions on Jeremy's report? Jeremy, have you had the opportunity to highlight everything that you wanted to?
Yes, I have, Sheila. Thank you very much.
Okay, thank you. And thank you for your report. I think I said it's developing. I think it is a very, very valuable report. But I know that you will welcome any further feedback on any details of the report. So thank you for that, Jeremy. Okay, can I move on? Quality, safety and improvement reports. We have a bundle. And Sue, I think it's over to you for the maternity services quality performance report. Or have I got that right? Yes.
So, yes, it is, Sheila. Thank you very much. I'm just mindful that Karen our head of midwifery, was hoping to join us this morning. She has been with a family managing an issue there. So if it's okay with the board, can I go through the other papers in the hope that Karen might still be able to join us? And should she not, then I'm happy to present the report at the end. Would anybody mind if I do that?
And I'm sure they won't. So where do you want to...
Karen's just joined.
Oh,
most excellent timing.
Shall we let her...
Well, I hope you've had time to draw breath.
Is she there? Oh, yes. Karen, did you want to head straight in, or do you want a few minutes and we'll go to my other papers first?
You're on mute, Karen, I think. Let's go to your other papers first. Karen, we'll give you time to sort your connections and make sure you're audible. And so, do you want to move? Where do you want to move to?
I'll go to the next paper. I'm just whizzing down the convene thing to bring that up for myself. So yeah, we'll go on to the next paper and then we'll go back to maternity. So the learning, quality and learning report, including learning from deaths. So really, the detail is in the report. I'm happy to take questions. I think it's important to note in this particular report that we do need a board minuting that we are delegating the authority for PSERF update and plans to go through the scrutiny committee, and they will approve the 2021 plan. And also just to say that there is a full narrative around the e-care alerts and the progress we've made on those. I'm not necessarily going to raise anything else unless anybody has anything they would like to ask me. I know David's got his hand up.
Okay, thank you. David?
Yeah, this one actually probably links to Karen's report as well. I think one of the learning from death reviews, it talked about having a helicopter view in maternity and around the supernumerary labour suite numbers. And I know when we come to Karen's report, that is a number that we're sort of not hitting at the moment. I know that we have had some staffing challenges which we're addressing, but given it's been raised as an issue from a learning from death, I'm just wondering what sort of priority we're putting on that to address it.
So, David, yes, we'll pick that up in the maternity report, but we are focusing on the supernumerary labour suite coordinator. That is a really key area for us. And you're right that we have had some staffing challenges, but I'll let Karen answer that question in more detail because she will have the absolute detail for that.
Okay, thank you. We'll save that for Karen. Can we just make a note of that for Karen, please, for the next section? And can I move to Angus?
Thank you, Sheila. I'm not sure, Sue, whether this is one for you or one for Craig, actually, but on one of the incidents, it was on slide 122 of Diligent, I noticed that there was an alert in eCare that for some reason didn't quite work properly, and it triggered a thought in my mind around the wider reliance we have on our digital algorithms thinking and the extent to which we're actually testing the algorithms are still doing what we thought they would, if that makes sense.
Yeah, it makes sense to me, so it must be clear.
Craig might want to answer that question.
So we're doing a lot of work on alerts, both to make sure that they do exactly as you say, so the alert works as intended, but also probably more significant because there is no evidence that the alert isn't working. It's that we have too many alerts and you get alert fatigue, so that people are clicking automatically through the alerts to get to the bit that they need to get to. So we're looking at both the efficacy of alerts in terms of people's behaviour as well as how well they work technically, but there isn't evidence that there is a widespread problem in alerts not working as they have been intended to work.
Thank you, Craig.
Does that answer your question, Angus?
It does, thank you.
Thank you. Okay, thank you for that. Right, so I think I haven't got any more questions for you. Thank you for a very detailed report, which by its very nature is self-explanatory. So thank you for that. Karen, are you?
I've just had a text from her. She'll be 2 minutes. She's just saying goodbye to the family that she's been with. So if you're happy, I'll move on to the next paper.
That's absolutely
we don't delay. So the infection prevention control paper, you'll see this is a slightly refreshed view of what we have been presenting to you. Both myself and Rebecca and the infection prevention control team are working through how we can develop a dashboard, I suppose, that really shows where we are compliant, in addition to the BAF action plan that we are completing and updating. So we want to be able to report to you, to us all, we want a report to be able to say what is our compliance for our day of admission swabbing for COVID, what is our compliance against day 3 and day 7. This is a new process we've moved to recently, which is we used to swab everyone on day 1 and then day 7 and then not again. In light of new guidance, we are now swabbing on day of admission, day 3, day 7 and every 7 days thereafter. So we're hoping that we will have that evidence and be able to show you our compliance against that. Rebecca and the team have done an amazing job looking at our compliance around day of admission swabbing, and the data is in there. You'll see that we've also incorporated the number of incidents relating to COVID-19 in there rather than in the IQPR, so it's transitioned into this report. To say that we have received, everyone's received some infection prevention control actions, key actions, that outline 10 key actions for us to undertake, and we will incorporate these in our BAF assurance framework, and we will do a gap analysis as to where we are. But we just to say that we are making good progress to meet those key 10 actions. I'm happy I'm happy to give details around our current outbreaks if that is required, but it's in the paper. If you need anything further, I'm happy to take questions.
Thank you very much indeed, and it's a very useful report, very valuable. Thank you. Do I have any questions from the board? Does anybody wish for any comment around the current outbreaks? Or are you happy we have sufficient information at this time? I think I take that as yes. I can see nods, and it's from a medic, so I will take that as being absolutely accurate. Thank you, Richard. Okay, in which case, thank you, Sue, for that. That was I think that's a really useful piece of work. Can we now go back to Karen? Is she with you yet, or shall we go on?
We'll go on. We'll keep going until let's finish all my papers and then we'll come back.
So you just alert me when Karen's in the room in case I miss her coming into the meeting, okay?
Yeah. So the next paper is the Improvement Board Programme Board Report. And again, you will see there is good progress being made with regards to the improvements and actions that we have. You will see that the maternity assurance visit has now been captured, and a number of the actions for maternity have been moved from black, which is complete, to blue as business as usual. And we now have it mapped out in the assurance programme, when we will be revisiting that to make sure that we remain in a position of business as usual. 2 plans have moved from green to black. That's the medicine management plan and the maternity up-to-date clinical guidelines. Just want to say we had an external quality assurance visit from the CCG to look at our medication safety across the organisation and in theatres and day surgery, and it was a very positive report again. And I'm really proud of this, that the visiting team reported how welcoming our team, our nurses and staff were, and how open and transparent they were, and how they really welcomed our visitors to the visit. And I think that's a really positive move, because this is an assurance visit, not an inspection. So we really want to get our staff used to being able to demonstrate where they are excelling and how proud they are of what they're doing. And special comments to the theatres, because they've undergone an awful lot of change in their processes, and they could absolutely articulate to the visitors where they were and how we were making progress on that. I'm happy to take any other questions, but I wasn't going to raise anything else specifically.
Thank you very much indeed. Alan, you had a question.
On the improvement board, Sue, I'm conscious that the improvement board and improvement committee is going to gradually extend its scope. Can you remind me what the process is for adding new things to that board's overview? In other words, let's say you've got learning from complaints, some random complaint that was there a couple of months ago. Are you picking up the embedding of learning from that, for example? So I can understand there's a million things that could go into that committee. What's the process for managing that?
So there is each exec has their own SRO cluster meeting, and we'll be picking up work through that to bring into the main action plan. So as things become business as usual, for example, maternity picked up some learning and some opportunities. The visit picked up some opportunities that we hadn't necessarily captured through the CQC visit, but they were additional things. So they will be now moved into that improvement plan. So we've got it all in one place. Individual learning from individual events will still be shared. We will make sure that we're able to cross-cut and share that learning, but any themes coming through will absolutely be added to the report or the improvement plan as necessary. So there will be oversight through the SROs, and then we will have them going to the improvement board, and you'll see that in the improvement plan, overarching improvement plan. Does that answer your question, Alan?
Yeah, I think so. I can tell it's just the danger is you get flooded with minor, tiny issues.
Exactly.
But if the SROs can manage that, then that's brilliant.
They will be the gatekeepers, yes.
Yeah, thank you.
Thank you much. And it appears to be working as, I don't know if Richard wants to comment. We sit on the improvement board, Richard Davis and myself, and it seems like a very efficient and well managed flow in and out. It feels that there's good pace, that there's real attention to detail. I don't know if you wanted to add anything, Richard, before I bring Steve in.
No, I just absolutely agree with that. It's been a great process, and very impressed with it.
Okay, thank you. Steve, you wanted to come in.
So links to Alan's question, but also how in the medium term the improvement programme board might link to the the 3I committee structure that we've got in the future as it links to insight, improvement and involvement and so forth. So that I'm sure there will need to be some sort of considerations of overlaps for that as we start to embed those committees, but also make further progress on this action plan and improvement plan.
Thank you for that, Steve. Thank you. So I think, from my sense, the improvement board really encapsulates a way of working, which is about attention to detail, which is about pace, but it's very inclusive because it does bring in a very wide range of engagement across the trust, both at senior level and below. So good work. Okay, so where are we on the agenda?
Karen is now here if you would like her to go back to maternity.
I would. Welcome, Karen, and I'm sorry to plunge you straight into the meeting, but I know your enthusiasm. I'm sure you'll be ready for us. So, and Karen, it's over to you. We'll go back to item 13.1.
Okay, so apologies first of all for being late, but I've also got Kate Croissant with me, who's our lead obstetrician, because obviously this is a very joint maternity service. So thank you. Hopefully you have received the report and have read it. So there's just a few little things that I would like to highlight before I take your questions. So This is an evolving paper that we have got. So just to give you an update on our strategy, that we are looking at our clinical governance more around our safety and quality strategy. We have got an external person who is assisting us with this, and we are hoping that will be we will have the framework by the end of this year, which is not that long away now. There has been a national HSIB report that came out in November that we are currently doing our gap analysis, and we will be presenting via our clinical governance in December. So we'll be able to give you an update of that, hopefully on the next board report. That was regarding the investigations into delays of intrapartum intervention. Learning from incidences, we have been continuing to present on the Learning from Deaths group, and that was about the previous maternal deaths that we have had, but we have also looking at the Embrace report that came out this year regarding the COVID, a very COVID specific edition, and we have presented that at our local governance, and we're having an action plan on how to make sure that we have addressed all the learning from that as well. The new kind of item that we have is our maternity dashboard. So we have still got the old dashboard, which was very our clinical decisions and outcomes, but we have also got our quality dashboard, which we think moving forward is really one we would like to present at this, which is all about our compliance with our appraisals, our training, our emergency checks, everything like that. So we still have got the clinical the clinical dashboard, which again, the number of women who delivered, we can't do an awful lot about that. The one areas that we need to be making sure, and we are ongoing working with, is about our postpartum hemorrhages. So we've still got a QI project that is in place, and we are monitoring the number of those very, very closely. The midwife to birth ratio for October and November, for October was high, and that really just demonstrates that the way that COVID has affected our staffing group, unfortunately, not so much that they have had COVID, but just the number of staff who've been absent due to having to wait for swab results to come back. And the supernumerary labour suite coordinator is an ongoing issue. It's not 100% that they are supernumerary. We are working with our NHS improvement officer, and we have a plan in place of how we are going to address that. We've also done some benchmarking, because I think the bigger units have they have more staff available, and so we have done some benchmarking in the area of similar size units on how they ensure their labour suite coordinators are supernumerary, and we're just waiting for 2 more of those units to get back to us, so we can do some cross-region learning. The mandatory training and the emergency checklists are on the dashboard. You can see how we have an evolving picture, and the majority of our checks now, we are in the high 90s. There are some things that we still need to improve upon. For instance, our prompt training across all staff groups, but we have done the trajectory, and we are hoping by April, the end of April, in all staff groups, we will be 100%. So that is, as long as we don't have any more, well, too much more sickness with COVID and such like. But yeah, that is our aim. The smoking cessation, the CO check, so using the carbon monoxide monitors had ceased due to COVID, but now that is now due to be recommenced. So we had changed our practice to enable us to make sure we were asking women about smoking, but we will re-audit the CO monitoring once we go live with that, which will probably be the beginning of the new year. And we've also got on there about our swab counts and our drug charts. So although they are red, you can hopefully see that we have got a trajectory of where we are improving, and we have done lots of highlights through our Take 5 messages to our staff, and we continue to audit and work on those. The CNST maternity incentive scheme, so that was on hold, and then it came out with a whole new well, the same indicators, but with some very new bits to them. So we are working to make sure we are going to be 100% compliant with those. And although the safety slide shows that we have got areas that we are still red and amber on, this obviously is another month on, and I'm very, very confident that we are working towards those. And we've had some good news about the MSDS. Our information team are 100%, they assure me that we will be compliant, so that is good. I have attached the Saving Babies Live Care Bundle version 2 report, which is in Annex C, and that's just give you an oversight of the commitment that the Trust has in providing the care bundle, and really this is about reducing the number of stillbirths that we have by 50% by 2025, and our current trajectory we are on target to meet that. So lots of work has been going on that. We've still got some areas, we've got an action plan as part of that report, which shows the areas that we're still working on, and we are very confident that we will have completed all of those actions. Hopefully you haven't got Annex D, this paediatric staffing report, that needed to be taken out. And then I have attached our Obstetric and Gynecology monthly governance report, just again to give you an oversight of what we share with our staff on a monthly basis at our governance, so that we are sharing our areas of investigations, our complaints, our national best standards, but also that we are sharing our great X's and our compliments as well. We continue to have our improvement officer who is working with us, who every 2 weeks we either meet in person or we have virtual via Teams meetings, and we are working through our CQC action plan. And as I could hear just on the back of the last conversation, that we are working, we've now put our shoulds on our action plan. We've always had that in the background, but we are very much working forward with those and making sure that we achieve all of those as well. And that's a very quick oversight. Has anyone got any questions?
It was certainly a whiz through an awful lot of granular detail, so thank you, Karen. I mean, it's good to have your particular take on it. I'm sure there will be one or two questions. Steve, your hand was up first.
Well, I just wanted to say a big thank you to both Kate and Karen, because it's a fantastic report. I love the quality dashboard. It's quite clear that there is now a granularity of reporting to the board. It's great to see the governance that goes to the teams. I think that gives us additional both assurance and reassurance around the focus on improvement. And it's good to hear that we're aiming to get to 100% on prompt by April. And I suppose my question on that is there any help and support that you need on that? But I just want to say a big thank you to Karen and Kate and the teams for all your work on this. It's really good to see this level of detail visible at the board level.
It is, absolutely. Nick, I think you were next, and then Rosemary.
Thanks, Sheila. Steve has said a lot of what I was going to say. It's been a real pleasure working with Kate and Karen on some of this, particularly on the prompt stuff, and with our anaesthetic colleagues to get that lined up. It's no mean feat. I just wanted to draw the board's attention to the fact that the governance section of this is it also relates to the improvement board report that Sue just gave. So we are using maternity as a pilot area for governance changes that relates to the improvement action 4.1 about making sure we pay attention to data. Clinical audit is the specific example the CQC gave, but we've widened it to data as a whole. So that action is pending trust-wide, but what it's pending is the completion of this trial in maternity, which I think the board can see today does look like it's going really well. So from an improvement board perspective, I think there is a positive link there as well that isn't obvious from the two papers, even though they're next to each other. So I just wanted to draw our attention to that.
Thank you, Nick. Rosemary?
Oh, thanks, Sheila. Thank you for the report. It really is excellent, and it's very comprehensive, Karen. I just wondered, in all of that detail, could you identify if there's any particular areas that you're concerned about or that we need to focus on? And if so, how we could support you in moving that forward?
Thank you. I still think I keep on saying we've still got a long way to go. We know we're not at our finishing point yet, and it is definitely progressing. And I think just with continued real joint working between obstetrics and midwifery, and we are definitely moving the service forward. So where that is continuing, that is where we are continuing our work and making sure that we're enforcing all of the things that we're putting in from the midwifery point of view, and we're actually supporting those with the obstetrician. So for instance, we've done lots of work around our governance, our safety and our quality, but it's now getting that support from the obstetric team as well, which we are getting, but it's at like the continued support there. Yeah.
Thank you.
Thank you for that. I've got Sue, and then I've got Alan. Then I'm going to. Oh, and I've got. Apologies.
It was only very quickly, Sheila, to say Karen didn't actually celebrate the fact that we went live with our continuity of carers this month, which was a huge step. We're leading the way in the region, so just wanted to say well done to Karen, because I know it hasn't been without its teething problems, but I think it's a great step forward, and just wanted to recognise that we have done that.
And I think we need to recognise these things really impact on real patients. I may be some years away from my childbearing years, but I know that the inconsistent mixture of staff you sometimes see can be very disconcerting, particularly for first-time mothers. But remember, all these improvements really impact on real people at a time when they're feeling fairly vulnerable often. Okay, Alan.
I was interested in your reference to benchmarking against a similar sized maternity unit elsewhere in the country. And I wondered, I'm conscious we are a small unit, have you got an ongoing link with one or two units that is something you can build on in a more general sense in terms of sharing best practice and learning from each other? Because I know it's very different from, say, Colchester, which is several times bigger, isn't it?
Absolutely, and I think it's really useful dashboard point of view. We can look across the LMS, we can absolutely benchmark because they're percentages, but when it comes to what we are finding is, because we're a smaller unit, you have less staff, because it has historically been on midwife to birth ratio, but actually we are still expected to do exactly the same as any other trust. So whether they have 10,000 births or 6,000 births or 1,000 births, we all have to do exactly the same from a standard point of view, from a CNST, from a safety, from all of the reports that we do. And that's the real difficulty that we have. So, and it's been quite interesting having our improvement officer who's used to working in a big London hospital, who actually, I think the initial thought was actually it'd be easier in a smaller hospital, but actually it's not. It's harder because you've got less staff. So that's why it's been really good to there's three units within the region that I am in regular contact with, that we do some benchmarking just for those real practicality side of things of how do you make these work when you have got a smaller amount of number of staff on the shop floor than the bigger units do. Yes.
Thank you, Karen. Karen, I'm going to say thank you to both you and Kate. Thank you for everything you're doing. Thank you for the detailed report, but thank you for the energy which just communicates itself through your presentations. It gives us great assurance, as well as the detail of the charts and the grids, that it's energy and it's people's energy that takes us into where we want to be. So thank you all. Thank you, Sue. A particular thanks to you, Karen, and to Kate. Okay, thank you.
So that then brings me on to the staffing paper, Sheila.
Yeah.
Which I'll just literally go through really quickly because I'm mindful of time. You will all be familiar with the format of the new revised staffing paper. Just the key things to pull out for this month were that our nurse staff fill rates were favourable, vacancy rates have reduced, and sickness rates have decreased across all nursing levels. Dan is here if anybody has any questions, but I'm happy to take questions if anyone has them.
Thank you, Sue. And I'm conscious we're getting a really detailed paper on staffing at our next board. And
Yes.
I'm sure that will be one of our main focuses for the next board.
Yeah.
So any questions for Dan? Welcome, Dan.
Thank you.
I think that we're going to say it's self-explanatory. Obviously, a really good piece of work, Dan. Thank you. Because I know that there's a lot of effort goes into the details on those reports. So thank you very much, and to the people who sit behind you and bring it all together.
Absolutely. Thanks so much.
Thank you, Dan. Could I then move to Future Systems Board report? Craig, this is your territory and our exciting positive part of the paper.
Thank you, Sheila. Absolutely. I think both positive and exciting. I wasn't going to pick out anything in particular. We've had a board workshop on this, only to say a massive amount of work has taken place in a relatively short period of time, and the pace is continuing, as you'll see from some of the discussions that we'll have in the closed board. But happy to answer any questions.
Thank you, Craig. And can I pass my thanks on to those members of your team and people like Jackie who've given up a lot of time for those board workshops, be it governors or be it the board itself, and have such a wonderful grasp of the detail. So to the whole team, to Jackie, to Gary, to Emma, the new comms lead, all the people who've been involved in that, and to Helena, you know, that there's a massive amount of work that sits behind all this, and we recognise that. And please, the board would want to thank them all, and not just you, Craig. Of course, it's good leadership good leadership that gets you there, of course.
I'll pass that on. Thank you.
Alan, you've got your hand up.
Yeah, great report, Craig. I'm conscious the clinical design work has been incredibly fast, and probably faster than one would want. Is there a process for the Attain work to be fed directly into that? Because they will presumably add additional learning, and that's been happening in parallel. Is there a clear process for the Attain work to feed into the clinical design workshops, maybe after Christmas?
So they are happening jointly, Alan. So part of the way in which we ensured that the Attain work was as informed and as least disruptive as possible was to merge the two. So Attain have been sitting in on a number of the clinical workshops because the work is inextricably linked. The idea is that we design what the future system will look like from a clinical perspective, but then Attain come in and view it through a lens as to what can happen quickly. So those two things have happened not just in parallel, but jointly.
Okay, that's really helpful. Thank you.
Thank you, Alan. Good question. Okay, can we note that report then, please? And then could we move on, please, to your digital update, which I think is fairly self-explanatory. It does occur to me that perhaps we should have a bit of a focus on digital at some future board meeting, particularly given the issues we've talked about with community and bringing them up to speed.
So I think that would be good as well as picking up on the previous item. So there's a lot of work that is going on under the future system umbrella around the digital programme as well. And we've had Atos, a company, coming in to help support some of the work around that. So a lot of my thunder on the digital programme has been stolen earlier in the agenda by my colleagues. But again, a huge amount going on, and particular praise needs to go to Sarah Judge, who is a fantastic member of the team and displays the same energy that you were commenting on in maternity. So there's nothing else to bring out on this, but a huge amount of work going on, and a brilliant team.
And part of the team that we as a board need to make sure that they feel thanked and loved, because they are doing an amazing job. But I think it would be good, and Richard, a note for you and I, that a future board meeting, I think actually a little bit of a focus on digital would be useful. I think, you know, we we haven't done that for a while. Okay, thank you for that. In which case, I'm going to move. Oh, Angus, my apologies.
Thank you, Sheila, and thanks, Craig, for the report. It's really heartening to see the progress that we've made on this and the way that we're leading on it. If I may just put an audit committee hat on for a second, I was reflecting on one. It doesn't feel that we have really looked at our cyber risk recently. And I wondered, it might be one for the audit committee, or it might be one that you can weave into, information security risk, should I say, when you can weave into that session on digital or somewhere else. But it did strike me we should perhaps just double check that.
And we will do that. It's worth saying that we recently had our Cybersecurity Plus status reconfirmed by the Department of Health. So again, one of the few organisations in the country that have achieved that. But again, happy to, I can weave it into that focus on digital, because there's also an awful lot to be proud of in that area as well.
Good. Thank you.
Thank you, Craig. That's reassuring. Okay, if there are no further questions, then I will propose we move, Richard, briskly to your governance report.
Yeah, thank you very much. I wasn't really going to say too much. The report pulls together a number of areas that were focused on, including reports from a couple of the key committees in terms of the Audit Committee, Council of Governors and Trust Executive Group, with a summary of the business within those. So from that perspective, it is just to provide the board with oversight of those activities. Unless there are any specific questions, hopefully the report is relatively straightforward and self-explanatory.
Thank you, Richard. I have no hands up, so I think we can accept that as self-explanatory. Thank you, Richard. Useful detail. Nobody has brought me any items of any other business, unless I have forgotten. I don't think I have any hands up either. That is good, thank you. In which case, can we note the date of the meeting, next meeting, please, which is in the new year. I will be moving to close this meeting, and you need to reconnect board members for the further meeting, and you may have 5 minutes in between. But before I do, can I say to the members of the public, I would very much appreciate some feedback on how it's worked for you. It's certainly worked better for me since I can see people. Angus, did you want to say anything before I just wind up? Your hands.
Sorry, I did just want to make a comment as a board member, and that's that I do think this pack has been really helpful and useful to navigate. So I didn't want to miss that point, because I know it's an area that we've given feedback on in the past. I'm finding it a lot easier to read the papers now than I did. That's me personally, anyway.
Angus,
I would absolutely agree with you. Sorry, Steve.
Well, I just wanted to comment on that, because in terms of our board preparation, I did thank all my exec team for, in a sense, the pruning of the papers to get down to about 181 in the public and about 120 in private. I think is pretty good. I've been reviewing other boards' papers, specifically Merseycare. They had 575 in their public board in September and 300 in November. So I think it's really important. It's no mean feat. I think we have got more strategic. And if you think about all the focus that we've had on maternity today, which, it was right and appropriate. If we didn't have that detail at the board, it would be further, in a sense, pruned. But I think we all acknowledge why it's important and salient to have that. So I think you're right to call that out, Angus. And I was going to say, I wasn't going to mention it, but I think it's probably appropriate to just say thank you.
Thank you. And you've both stolen my thunder. So I think it's really important. I feel as if people are more focused on key items at any one time. And that means actually the discussion has the potential to be much deeper. So I do think it's an extremely positive move. What's not so positive is the chairman's overrun on time, but I think, you know, we're giving more attention to the things that really matter. And I do want to say thank you to the people who've come in, like Karen, like Jenny, because it's really good to have that direct input from the people who are much closer to the workplace than we are. So that's really helpful, I think, in giving us assurance. But to all of you, and particularly to the members of the public, because I will see the board members again before Christmas, but can I say to members of the public I may not see, I hope you have a wonderful, if rather quieter probably than usual, Christmas, and a happy and healthy new year. I hope that 2021 is a little less difficult than this year has been. I suspect it won't be. It will be difficult in other ways. But one of the things is I do hope that we will be able to meet again properly in the presence of each other, because I think we've all missed. We're getting much better at the technology, especially when I can see you. But we are getting better at it, but we miss that human contact. We miss that ability to see each other properly and to be able to interact in a human way. So happy Christmas, happy and healthy new year, and safe journey home through the snow if you're in Suffolk. If you're going home, you may already be tucked up in the warm. You probably are. So thank you and bye. And I'll see you in 5 minutes.